Hi, everyone. My name is Megan Klink, and I am the CEO for Susan G. Komen Orange County. And thank you for joining us today. We are creating this. This is the first episode in a series that's focused on breast health and the breast health community, under this COVID-19 pandemic. And our first conversation today is going to focus on breast cancer screening and treatment recommendations. And we're joined by two incredible experts, Dr. Lisa Guerra and Dr. January Lopez, and a little bit more about both of these incredible women in a moment. But I do also want to thank all of you who answered Komen's call last week when we said we were going to have this conversation, and we asked you all, what do you want to ask our experts? And really helped us frame the conversation that we're about to get into. So thank you to our breast cancer survivors and those of you living with metastatic breast cancer for making today possible as well. And I have to say, this is an incredibly timely conversation for lots of reasons. And the LA Times just published an article today in their science section around how the coronavirus is forcing breast cancer patients to make tough decisions. And so really, really grateful to Dr. Guerra and Dr. Lopez for making time that you do not have to be with us today and really help address some of these questions. So with that, I do want to properly introduce you both. And I also want to share with everyone that we are very fortunate at Komen Orange County to have you both serve as members of our board of directors as well. So thank you for that. But first, let's start with Dr. Lopez. Dr. Lopez is currently serving as Director of Breast Imaging for the Hoag Breast Program, and is an expert in breast imaging and interventions, and an outspoken advocate for access to breast cancer screening. Dr. Lopez has spoken in numerous national and regional forums, including events for the National Consortium of Breast Centers, and has authored several radiology manuscripts and textbook chapters, including the journal Radiographies, and 3 well-known breast imaging references: Breast Imaging, Diagnosis of Diseases of the Breast, and Breast Cancer, A New Era in Management. And joining Dr. Lopez is Dr. Lisa Guerra, who is a board-certified breast-dedicated surgeon working out of the Breastlink office in Newport Beach, and previously served as part of the Hoag Breast Center team, and also as an assistant clinical professor of surgery for USC's Keck School of Medicine, and has been serving the Orange County area patients for more than 10 years. Dr. Guerra's professional areas of interest include oncoplastic surgery, intraoperative radiation therapy, and management of high-risk patients. Thank you both for being with us today. We're ready to dive into the questions? Great. Dr. Lopez, we're going to start with you. And so our first question are, what are breast cancer screening recommendations during COVID-19? And if you can focus on signs and symptoms and when someone should call the doctor or schedule an appointment.
Okay, thanks, Megan. So, ever since Governor Newsom issued a stay-at-home order, we know that the mandate has been for essential to stay at home, right? Shelter at home, unless you need to go out for something that is essential. So for most things that we do, deciding if something's essential or not essential is, relatively straightforward. If you don't have food in your refrigerator, that you got to go to the grocery store, that's essential. If you need your nails done, maybe going to get your nails done is not so essential. But when it comes to healthcare aspects, I think those lines can become somewhat blurred. So when we are thinking about the fact that screening mammograms, we know, save lives, right? They prevent many women from dying from breast cancer. To say that that's an essential exam would not be wrong. So when we're talking about healthcare exams, we kind of turn to the CDC and other professional organizations to think about things more in terms of urgency rather than essential versus non-essential. So the CDC basically recommends that any exams that are not urgent, and they actually include screening mammograms in their list of examples, should be rescheduled or postponed. And there are other professional organizations like the Society of Breast Imaging, the American College of Radiology, and also the American Society of Breast Surgeons, who also recommend that screening mammograms be postponed during this kind of COVID crisis. if postponing your life-saving screening mammogram gives you a lot of anxiety, I'm just going to mention a couple things maybe to kind of help put things in perspective. And one is that we must remember that when women are undergoing screening mammograms, these are for women who are asymptomatic. So screening by definition is done in a woman who doesn't have any active breast problems, is totally asymptomatic. We're just screening this woman who doesn't have any symptoms to see if she happens to have breast cancer, because we know that 1 in 8 women will develop breast cancer at some point in their lifetime. But if you look at all the screening mammograms that are done, let's say in a particular day, only less than 1% of women who undergo screening are going to have breast cancer. So that means more than 99% of the women who are having a screening mammogram on any given day are just normal women. They don't have breast cancer and don't have any issues. So what about the women who actually do have breast cancer? Even though the number is very small, there are going to be some women who we are going to detect on screening. So then I kind of look at it as in terms of breast cancer and how it develops. And we have to remember that breast cancer develops from one single cell, and in most cases will take many years before it becomes clinically evident from that one cell. So in the world of breast cancer, when we're talking about time, waiting a few weeks or even a few months is very, very unlikely to make a significant impact on a woman's prognosis or a person's prognosis. Or on their treatment course, by waiting a few weeks or months. So that just kind of puts things in perspective. The recommendation is not to not have screening. The recommendation is to postpone screening until a later time. So kind of looking from screening to diagnostic imaging, I'm just going to, since you asked about symptoms, diagnostic imaging is what we do for women who have symptoms. So that means if you have a breast lump that you feel that's maybe new or is enlarging, skin changes or changes in the contour of the breast, nipple discharge or nipple retraction, those are all kind of symptoms that sometimes are signs of breast cancer. So we know that, most breast cancers, most patients who are symptomatic still don't end up having breast cancer, but that's a different scenario than when we're talking about women who have no symptoms, because the likelihood that a woman who's having symptoms like that might have breast cancer statistically is higher, right, than someone who has no symptoms. So we, Hoag and I think most breast centers are still open to take care of patients who are actively having breast symptoms. And I should also mention that when women have symptoms of breast infection, like fever, breast redness, pain, skin thickening and changes, that's really the one breast situation that actually can be not only urgent, but can be emergent, and very rarely can be life-threatening. So we certainly want to continue to take care of patients who have symptoms, because, those are more urgent cases than women who are asymptomatic. But those are kind of the recommendations for where we are right now. Things are actively changing, seemingly from day to day. But that's kind of how the situation is at this point.
Thank you so much, Dr. Lopez. Dr. Guerra, if you could take a moment to share, what is it that you're seeing around the prioritization and treatment and triage of breast cancer patients? That would be great.
Yes. And just like Dr. Lopez was commenting, things are changing on a daily basis, if not an hourly basis. Sometimes it seems, just as the radiologic societies have given their guidance as far as breast imaging, we have, as surgeons, have gotten some guidance from the Society of Surgical Oncology and the American Society of Breast Surgeons about how best to prioritize even our breast cancer patients. And a lot of that initially had stemmed from the concern about what an individual area's resources might look like in terms of personal protective equipment for our healthcare workers, in terms of ventilators, in terms of healthy staff functioning at a medical facility or at a hospital setting. And so they were making some guidelines as far as what the recommendations might look like if we did need to prioritize who went to the operating room. A lot of the prioritization came down to what things are more urgent and what things could be postponed for a period of time. And so there are still some individuals that are going to be prioritized for the operating room in situations where someone does have an infection, particularly if they're septic, or if someone has an expanding hematoma where they are hemodynamically unstable, so bleeding complication that needs to go to the operating room. Those are still considered to be actually our top priority patients for going to the operating room. But really the majority of our breast cancer patients are being prioritized kind of as a second level. And those individuals where we're really saying that we should get you to the operating room include individuals that have started their breast cancer treatment through things like chemotherapy, where surgery would be the next course of treatment. We're still advocating for those individuals to proceed forward with surgery after completion of chemotherapy. Now, there are some situations where we're unsure of what sort of medical treatment they may ultimately have recommended. And so for those individuals, also surgery may be deemed to be a priority in determining what's the appropriate cancer treatment for their particular situation. In individuals that have a cancer that is progressing despite treatment, those also are going to be prioritized for the operating room. But the vast majority of breast cancer patients fall into a category where they may be able to be treated with medications before we take them to the operating room. Those are cancers that are fueled by hormones, what we call estrogen receptor and/or progesterone receptor positive cancers. Those individuals, as one of the courses of treatment, would typically have a recommendation to take endocrine therapy. This type of medication, including tamoxifen or a class of medications called aromatase inhibitors, traditionally in the United States has been prescribed as kind of the end of their treatment course. In Europe, it has been used much more commonly as a bridge to when they might go to the operating room. And we're seeing more recommendations to consider treating patients in that sort of fashion as taking those hormone blocking medications, which are still considered to be a very important part of their cancer treatment, and just changing the order around a little bit so that they may be initiated with that treatment before we take them to the operating room. Now, again, when we were talking about prioritization for taking patients to the operating room, the initial push and function really seemed to be more so in terms of resources. Who did we have enough equipment for, ventilator support for, staff for? But I think a little bit of the shift more recently has been taking into consideration the what if sort of scenario. What if we have a patient that has coronavirus but is asymptomatic and we take them to the operating room? Well, if they're asymptomatic, they're not having symptoms. They haven't been having the fever, the shortness of breath, the cough that would have otherwise caused us to say, oh, you are not in a situation we want to take you to the operating room right now. But what if they develop those symptoms after you have already completed surgery? Studies that have come out of other countries that have looked at this information have identified an up to 20% mortality rate for those individuals that become symptomatic with COVID-19 after their surgical procedure. So I think that that has also been an additional concept that we're adding to our conversation with our surgical patients, because currently we don't have enough tests to test the symptomatic patients for coronavirus, let alone patients that may be going to the operating room that are otherwise asymptomatic. So it is introducing an additional layer of conversation with our patients. Again, there are additional situations where we may prioritize a patient to the operating room. For instance, the minority of those cancer patients that have estrogen receptor negative but early breast cancer, if we're concerned that there could be some invasive breast cancer, but we're still trying to determine what they might need from a medical-based approach. So there always are going to be those situations where we as surgeons need to talk with our patients. We may need to talk to their other treating physicians to try to determine together about what might be the safest pathway to take. And in some cases, it's not going to be our traditional pre-COVID-19 sort of era treatment, but it may be a treatment that we need to kind of make some compromises for to help and determine what we feel is going to be in that individual's best benefit.
Thank you, Dr. Guerra. And truly it's a scary statistic around the 20% mortality rate. And I think that for those who are listening to this conversation, that yes, while that statistic is really scary, their breast cancer is also really scary for them. There's so much fear and anxiety that's already, and then adding in COVID-19 has just really heightened that. So is there anything from either one of you, Dr. Guerra and Dr. Lopez, of additional information you can share to help allay anxiety for patients and their families, you know, as we go through this health crisis together?
I think we were both on mute, so I apologize, but I think it does need to come down to a conversation like what Dr. Lopez was making mention. Most cancers may take really years before they are evident on imaging, years before they can form into a lump in the breast, and years before they can cause something more dangerous to happen. So it is a scary sort of premise when we're talking about perhaps changing around the timeline of their treatment. But I still feel like for those individuals that do have a recommendation that their surgery be postponed, it's not that they're not going to be treated during that time frame. They will be receiving some form of active treatment, something that's going to try to help kill their breast cancer. So for some of those individuals that are going to need chemotherapy as part of their treatment for their breast cancer, we're going to start their treatment off with chemotherapy. So we're going to be actively trying to kill their cancer cells before we take them to the operating room. For those individuals that will benefit from hormone blocking medications, we're going to be actively giving them pill medications that are going to help ideally try and kill their cancer cells. And it's really going to be those individuals that we question whether they're going to benefit from chemotherapy, or those individuals that we really don't think are going to benefit from our hormone blocking medications that we may otherwise be prioritizing to take to the operating room, as well as those that again are finishing up their chemotherapy treatment. So nobody is saying to not give treatment. We do want to still actively give treatment for their breast cancer, but again, it just may be the order of treatment that may be changed.
Yeah, I just wanted to add also for those women who are, and men who actually are coming in for diagnostic imaging for symptoms and things like that, I think just my own personal observation, you know, I think the state of California has done a pretty phenomenal job at social distancing, and we can see that because, you know, the curve looks entirely different from, you know, other places where they weren't able to start perhaps as early, like New York. And what that's allowed us to do is kind of stay at least so far, knock on wood, you know, below that line of the resources that are needed to take care of these patients. So what that's also allowed us to do, right, and not doing routine screening exams and not urgent exams, is to provide an environment in our breast centers. And I've heard anecdotally from, you know, people at many other breast centers in Orange County as well. I think that everyone's kind of following these same very precautionary lines, where we're really trying to do really good social distancing inside of our breast centers as well, to take care of patients who are coming in and needing to have care, doing those really good deep cleanings, you know, germicidal cleanings of all the equipment in between all the patients. And I know Hoag, along with, I think most of the breast centers around Orange County, are requiring mandatory masking of the staff and the physicians when they're interacting with patients. So, you know, even when patients who have to come in and have to have diagnostic imaging, you know, I want patients to have some sense of feeling of, you know, security that all the steps that we can take are being taken to you know, for their safety when they come in.
Great, thank you both so much. And before we wrap it up, I just wanted to ask if there's anything that you feel like we should be sharing for people who are tuning into this that we haven't covered already.
I think one thing I didn't touch up on was a question that people had with regard to breast reconstruction. And a lot of our plastic surgery colleagues are not able to do their elective sorts of cases, but in individuals that do require a mastectomy as a component of their treatment, they are still being typically offered the option of breast reconstruction, but typically that is tissue expander or implant-based reconstruction. So for instance, if someone is wanting to do reconstruction using their own body's tissues to do that reconstruction, typically those sorts of what we call autologous reconstruction cases are being postponed until we are outside of this pandemic era. So implant-based, tissue expander-based sort of reconstruction is still being allowed for in this period of time.
I would just say, let you know, probably the most common question I'm asked by my friends and family and people who live outside of California is, have you had to go work in the emergency room or take care of patients with COVID? And I just want to say no. The answer is no, thank goodness. And I think this is just a testament to the fact that social distancing is working. So please stay at home so that I don't have to go to the emergency room and take care of patients with COVID-19.
Absolutely, thank you for that. Let's keep that social distancing up and flattening the curve so we can return to some level of normalcy sooner rather than later. And again, thank you both so much, Dr. Guerra and Dr. Lopez. We're so grateful for your time and expertise and sharing that with everyone who is a part of the Komen Orange County family. And for those of you who listen and you have more questions, please do share those through our social channels, or you can send us an email at info@komenoc.org, and we will absolutely do our best to respond to all of that in a timely manner. And certainly it could provide content for a future web-based conversation through this series that we're calling Caring Through COVID-19 Together. And truly, we are all in this together, and hope you all stay safe and be well. And thank you so much.